Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a 68-year-old patient suddenly starts asking the same questions again and again. Where am I? What happened? Why are we here? The family is frightened because the onset is abrupt, but the patient is awake, fluent, recognizes themselves, has no weakness, no aphasia, no visual field loss, and no seizure activity. This is the classic clinical setting where transient global amnesia should come to mind. Transient global amnesia means an abrupt, isolated failure of new memory formation. The patient cannot lay down new episodic memories, so they keep repeating the same questions, but their identity remains preserved, and the rest of cognition is largely intact. It usually affects patients over the age of 50, and by definition, it resolves within 24 hours. The key structure to understand is the hippocampus, especially the CA1 region, which is vulnerable to transient metabolic and vascular stress. A typical trigger may be exertion, emotional stress, pain, sexual intercourse, Valsalva, or cold water immersion. The sequence is trigger, then autonomic or venous or metabolic stress, then hippocampal vulnerability, then impaired encoding of new memories. That is why the patient can speak normally, pay attention, and interact, but cannot retain what has just happened. MRI can support this mechanism. Diffusion-weighted MRI may show small punctate lesions in the hippocampus, often seen best 24 to 72 hours after onset. This timing is important because very early imaging may be normal, so a normal early scan does not exclude typical transient global amnesia. Clinically, the classic feature is sudden repetitive questioning. This happens because working attention and language are preserved, but anterograde memory consolidation fails. Mild retrograde amnesia may occur, so the patient may lose some memory for events before the attack, but they should still know who they are. The important negative features are just as important as the positive features. There should be no aphasia, no hemiparesis, no visual field loss, no ataxia, no impaired consciousness, no seizure activity, and no persistent confusion. Headache, nausea, or dizziness can occur, but they should not dominate the picture. If they dominate, think again. Do not confuse transient global amnesia with transient epileptic amnesia. Transient epileptic amnesia is usually due to focal temporal lobe epilepsy. The spells are typically brief, often less than 1 hour, and recurrent. There may be motor automatisms or olfactory hallucinations. Motor automatisms are involuntary, semi-purposeful movements during a seizure, usually without full awareness, such as lip smacking, rubbing the hands, or picking at clothes. MRCP trap. A single prolonged episode of repetitive questioning in an older patient suggests transient global amnesia, but recurrent short amnestic episodes with automatisms suggest temporal lobe epilepsy. The diagnosis of transient global amnesia is mainly clinical. The pattern is acute, witnessed anterograde amnesia, preserved alertness, preserved personal identity, no focal neurology, no epileptic features, no head trauma, and complete resolution within 24 hours. When all of these are present, the diagnosis is usually secure, but investigate when the story is atypical. Red flags include focal neurological signs, reduced consciousness, recurrent brief episodes, seizure features, severe headache, fever, metabolic disturbance, anticoagulation, head injury, or incomplete recovery. In those settings, the differential becomes much broader. You must think about posterior circulation TIA or stroke, transient epileptic amnesia, complex partial seizure with a post-ictal state, migraine, hypoglycemia, intoxication, Wernicke's encephalopathy, encephalitis, and dissociative amnesia. Management is supportive. Observe the patient in hospital until they are clearly improving, exclude dangerous mimics, and reassure the patient and family. No antiplatelet, anticoagulant, or antiepileptic treatment is indicated for typical transient global amnesia itself. The prognosis is excellent. Recurrence can occur, but most patients have a single episode, and typical transient global amnesia does not behave like a TIA. If you remember one thing, remember this. Transient global amnesia is sudden anterograde amnesia with repetitive questioning, preserved identity, no focal neurology, and recovery within 24 hours. Quick recall. A 62-year-old develops sudden repetitive questioning after cold water immersion. He is alert, fluent, knows his name, has no weakness, and recovers fully within the same day. What is the most likely diagnosis, and why is he repeating the same questions? The answer is transient global amnesia, caused by transient dysfunction of hippocampal memory circuits, leading to failure of new episodic memory encoding. A patient has recurrent 20-minute episodes of amnesia, sometimes with lip smacking and a strange smell before the episode. Why is this not typical transient global amnesia, and what diagnosis should you consider? The answer is that recurrent brief amnestic spells with motor automatisms or olfactory hallucinations suggest transient epileptic amnesia due to focal temporal lobe epilepsy. Do subscribe to the channel for further videos.